and Ms. Bindu Saju and Golma, moderator, and all EC member of TNA Delhi branch, all participants, dear students. Good afternoon to everyone, and also welcome you all for our 13th Empowered Nurses to Empower Nurses in India. It is my honor and privilege to welcome our National Vice President Anik Kumar Madam. I think he's muted. I think someone. There is interruption. Prashant, can you mute? Yes. So it is my honor and privilege to invite our National Vice President Anik Kumar Madam. I think everyone knows her, but as for me, she is a great leader. As a great leader, always create more leaders, never not followers. That concept, the statement was true. Is given by many people. I realized myself as one of the leader in TNA Delhi branch, and I perceived from her the way she motivated me, my team, to do the best, and also she also made me to set my own visions, because usually we have to expect the leader to follow their visions. But every time she keep on telling me, my team, do the best and set your vision and do the change in the changes of the status of the nurses across India. That's why I'm always admired her. Welcome you, madam. And I welcome. I'm also happy and I'm very proud for me to invite. Welcome Dr. Suresh K Sharma, Professor cum Principal in College of Nursing, AIMS Jodhpur. Everyone knows that his work is well-known personality across India. He is also inspiration, not only me, to all young professionals today, because of his work he's done as an academician, researcher, administrator. So because it's all he made it in his own pathway, that's why we always admired him. And we are really happy to hear from him today. Welcome, Dr. Suresh Sharma. And again, I'm very happy and delightful to welcome today another speaker, Deepa Chow. She is I witnessed her work when I visited National Heart Institute, because she is the head of the nursing service and National Heart Institute in Delhi. And she's doing exemplary work, not only working at doing at a National Heart Institute, and also she is the NABH assessor, and she improved the quality not only at the institute level, at the national level through that setting of the standard of the nursing care in different level. That's why our topic also is going to be very interesting to hear from her today. And again welcome you all for today sessions. But before concluding that welcome, and I would like to just to express about this concept of this webinar. So everyone knows that this is a topic. We have the 13th webinar on empowered nurses to empower nurses. The empowered nurses means what today you are going to see the speaker are going to listen from them. They are the empowered nurses who are self-motivated and motivate others. Others means today the empowered nurses. They also had the same kind of journey what I had, or what Annie madam, or everyone senior people. They also had the same kind of very hardship and very challenges we have gone through our professional life. Every nurses in India, we used to have that type of challenges, no doubt about it. But they also had, but they taken their own pathway and they are overcome only two reasons. Number one, they are self-motivated, and at the same time they are enjoy with their work, and they are able to today to stand in front of us as an empowered nurse. That's why TNA is doing the two dual things. Number one, we are recognizing that nurses who are doing exemplary work in education, nursing education, administration, or the service side, to call them as empowered nurses, and Delhi branch and TNA headquarters collaboratively calling them and invite them to give the chance for them. At the same time, we are also honoring them in this forum to say a few words, to share their vision to the other people. This is called the empowered nurses to empower nurses, because the reason nothing is behind that. TNA is tireless, we even lost the Madam Annie Kumar with me, then we know that so many, agenda, we have so many steps we are taken by today our President, Dr. Roy, to improve the nursing standard and improve the welfare of the nurses. This all not happen by one day. It takes time, definitely, but same time it's all need to be supported by nurses. The support means we have a number of nurses across India, no doubt about with the number. We are the majorly compared with any other professionals. But our most important, all majorly number of nurses, maximum number of nurses, all nurses at India, they should be turned into the quality manner, and also at the same time, they should contribute the way what we contributed during COVID. That only influence the policymaker to accept and to become, the nursing profession what we supposed to do at par with other countries. With that, I just once again congratulate to all of my team members who taken the effort to bring up this program. It's almost the 13th. We'll go almost we reach 100 also. We're expecting that. And have a good day. Once again, welcome everyone. Over to Annie Madam to say a few words. Yes, Saini.
So Annie ma'am is there.
Yes,
she's there. Yeah.
Thank you, Govi sir, for your kind words. And a warm welcome to all of you, dear. Some introduction. Great pleasure to have to address you all for this auspicious occasion of the 13th webinar conducted by TNI Delhi State Branch. I would like to express my heartfelt gratitude to and appreciation to the President, Dr. Govi Chandran, Secretary, Mrs. Shaini Chako, Bindu Shaiju, the Nursing Education Chairperson, Yangchen Dolma, Nursing Services Chairperson, to acknowledge that you all are doing a great work by empowering. You all are sincerely committed to empowering the nurses of Delhi, I should acknowledge. Today, as we all know, it is the 13th webinar, and so far, all the topics chosen help the nurse professionals to gain insight and information that would remain effective in their life as well as in their professional commitments and work. Of course, these webinars are going to help them to improve their leadership quality, attitude, confidence, and communication. That's bring about improve the patient care along with changes needed in their own lifestyles also. Because you had chosen topics which will enrich them in their professional life as well as in the personal life also. Apart from this, this is a great occasion for me to welcome our eminent speakers of this webinar. Our speaker of the day is Suresh K Sharma, Principal Professor, College of Nursing, AIMS, Jodhpur. He doesn't require an introduction, as he is a well-recognized personality in our profession. We all know that he is known for his wonderful contribution and high achievement in the profession. I welcome you, sir, and I'm sure that all the participants are going to be benefited by your session. As you yourself is a successful nurse who, with your creativity, knowledge, and management skills, helped in enriching our profession and healthcare system as a whole. Thank you, sir, for accepting this invitation and giving the session on the nurse entrepreneur, which I think all will be benefited to attend to. Our second speaker, Ms. Deebachuk, who is going to speak on recent advances in clinical nursing practice. She herself is the head of Nursing Services, National Heart Institute, New Delhi. And this topic is also very appropriate, and I can say it is the need of the hour too. Thank you too, madam, for accepting and contributing to empower us about the recent advances in clinical nursing. Once again, I take this opportunity to congratulate and give my appreciation to the leaders of the Delhi State Branch for their commendable efforts to enrich and empower the nurse professionals in all the ways they can. Keep it up. At last, welcome all the participants who have registered for this webinar and making it worthwhile. I am sure that the webinar will be profitable and fruitful for every one of us present here. Thank you one, thank you all.
Thank you, Annie ma'am, for the special address and for addressing the group. I bring greetings to you from TNI Delhi State Branch. A very good afternoon to all of you. It gives me immense pleasure to introduce our eminent speaker, Dr. Suresh K Sharma, who is PhD in nursing. Sir is currently working as the professor and principal College of Nursing, AIMS, Jodhpur, Rajasthan. Dr. Suresh has more than 20 years of experience as nurse, academician, nurse, researcher, and leader. Doctor has the postdoctoral fellowship of Nursing Research Society of India and prolific writer, authorized 6 and edited 5 textbooks, and he has contributed more than 150 research papers in index journals. Sir is the founder president, Society of Preoperative Nursing India and Society of Critical Care Nursing India. He's also the board member in International Federation of Preoperative Nurses. Very proudly, I say, Sir was the secretary of Trained Nurses Association of India, Uttarakhand State Branch during the tenure 2014 to 19. Dr. Suresh has delivered 12 international and more than 150 national keynote invited talks in conferences. A few about Sir's awards and honors. He is a recipient of Florence Nightingale Award 2001, which is awarded by the Florence Nightingale Nurses Welfare Association, Bangalore. And he has received the Best Paper Award, Depression and Anxiety among Healthcare Workers during COVID-19 pandemic in India. Dr. Suresh is the best teacher. He has received the Best Teacher Award from AIMS Rishikesh in 2018 and the Best Original Research Paper Award in Southeast Asian Diabetes Foundation Conference. Now, I request Dr. Suresh K Sharma to brief us about the nurse entrepreneurs. Over to Dr. Suresh.
Thank you so much, Madam Saini, for your kind words. At outset, I would like to express my heartfelt thanks to President, TNA Headquarters, Professor Roy, and my heartfelt gratitude to Madam Annie Kumar, Vice President, North Zone, TNI, and my special thanks to Dr. L. Gopichandran, President, TNI Delhi Branch, Madam Saini, Madam Bindu, Madam Dolma, and entire organizing team for giving me opportunity to be here today. They have assigned me to talk about a very sensitive and very important topic today, that is developing a new generation of nurse entrepreneurs. This is a talk of the time globally, and it is nice that we are here today to discuss about that. Give me a moment. I'll start sharing my slides and then we'll talk about them. Hope you can see my slides.
Yes, sir.
Thank you so much. I'll be, for next 18 to 20 minutes, I'll put a light on how to develop new generation of nurse entrepreneurs in our own country. Today, we all have an impression that whoever is trained as a nurse, she is a job seeker, but she is not an entrepreneur to create the job for others, including their nursing colleagues and non-nursing colleagues. And we need to think about that. You all have seen a lot of businessmen have made a lot of money by bringing out nursing institutions in India last two and a half decades. But there are only few nurses who could do that. There are many other things which our nurses can do. It is very much into their own domain, be it a bed or a bed mattress or a syringe or any catheter which is used, and many other care interventional devices which are used by nurses and healthcare professionals day in, day out, where nurses has really contributed into idea, but they never have claimed to be entrepreneurs. And this is a high time. The young brain, which is very energetic, need to think about that. My agenda of talk will be meaning of entrepreneur, who can be entrepreneur, importance of entrepreneurship, merits of being entrepreneur, scope of nurse entrepreneurs in India, path to become an entrepreneur, difference between entrepreneur and intrapreneur, and organizations supporting nurse entrepreneurs in India and globally. If we say the term entrepreneur, a person who set up a business or a startup or a business taking on financial risk for hope of profit. A nurse entrepreneur uses their nursing education and experience to start their own healthcare related business. So we say passion plus skill plus nursing gives to a business idea, and that is called as nurse entrepreneur. Who can be entrepreneur? There is a creativity, hard work, and business skills. If the person has these three things, and in addition can have accounting, marketing, sales, and developing a customer base, can be an entrepreneur. Importance of being entrepreneur, we all know. They can create job for others. They can have innovative pathway for themselves. They can create a change into not only their own life, their own discipline, but in the economy of country. Give back to society and adds the national income. There are merits of being entrepreneur. You can be your own boss. There are unlimited income potentials. There's a flexibility into working schedules, which are required for women who are primarily the nurses. Impact on society. There's a leadership role. You are lead into your own business, which you are doing. Growth for self lies on your own terms and conditions. Life goes like that. Feelings of fulfillment, because you achieve fame, you achieve money, you achieve your dreams, which you think that you need to be. There's just, what is the scope of being nurse entrepreneurs in India? There are only few things I'm highlighting, but this could be beyond that. You can be an independent service nursing, service offering person, and there had been a lot of new startups have started during COVID pandemic. A lot of nurses have started, and non-nurses, hiring nurses, they have started this business, providing home care nurse. We all have seen during COVID pandemic, nothing else has worked, neither any drug, any surgery, any medical intervention or device, but only care have worked. And now people started thinking about care as an idea to make it as a business. Home care nursing have taken a big step in India, and during COVID, it has flourished, and it is giving a good scope of being entrepreneur for nurses in our own country. Health products and medical devices, where you can have an idea, you can have a patent, and you can start getting royalty dividends out of it. For example, there are many jugards which nurses have done in India in many devices, but hardly they have thought about they can patent it and they can start, getting a royalty when they transfer this idea to an industry and industry start producing products. Let me give an example. Today, we have many task trainers which we are using in nursing education. And most of, I won't be wrong to say all of the products are coming from other countries. None of them are produced in India. Nurses in India have, developed their own products to teach nursing students into their skill labs and fast. The same can be transferred now in a refined manner, patented, and with the industry partnership, they can be produced in low cost. Let me give an example where I have my own patent. There's a gluteal muscle task trainer, which we are buying from Korea and US with Lardal. It cost us huge money, approximately 1.5 to 2 lakh rupees. And if we produce same in India with our own idea, which has a better features, we can produce hardly 20,000 Indian bucks. And there's a huge market in India. Only people are not able to afford because of high cost. So this is a low cost, high quality solutions with our own ideas. And nurses have potentials to do that. Industry consultation, I tell you, Nurses in West, my lot of colleagues from UK and US and Australia, they pass on their expertise to the industry, like when the new hospital is built, nurses work as a consultant with an architect, what should be where. And because they spend most of the time, more time and larger time with patients in healthcare system. So they understand the intricacy, how a operation theater need to be in a ward, where should be the wash basins, where should be the locality of utility, either dirty or clean utility, where should be the washrooms to be located, so they disturb the patient less when they are sleeping in the night, how the lights, illumination should be there. So their inputs are more important than anybody else. But in India, we are not thinking into that direction. And industry consultation can be a huge entrepreneur scope for nurses in India, where let us take another example, like Godrej is producing hospital furnitures, even nursing stations, the beds where nurses can act as a consultant, being entrepreneur. The training and nursing education is going on. There are large number of nurse entrepreneurs who are doing it, and they are earning good dividend out of it. Writing and publishing is another entrepreneurship, which yes, many nurses are doing in India, and they are earning dividends out of it. Blogging, hardly only few of them do it, but blogging also gives you royalty dividends. Career advices and placement centers, yes, there are nurses, and non-nurses, large amount of non-nurses are involved who are giving career guidance and placement of nurses into Western world and in Indian private hospitals. But these are the few examples where nurses themselves can think to the scope of entrepreneurship. There's a pathway of becoming entrepreneurship. First thing is you need to begin. You need to take a first step. And that is an idea and a potential idea you have in your mind. And then you create a business plan of that idea. And then you think for funding for this idea. And every idea does not require funding, but few ideas require funding. So think for funding, create a business brand out of it. And there are industries which help you to create a brand out of it. Define the best business structure, secure the rights of by patenting or earning copyright for your work, and then you start operating on it, revise it, and then make it a successful business plan. You can do it. And there's a path begins with a vision, and then you have a goal, strategy, action, and ultimately you will success. Success happens with a start, and start happens with a thinking, and thinking crystallized by analysis, planning, and then you try. Most of us doubt the self, and we don't do it. If you do not do it, you can't reach to success. You do it again, keep doing, ultimately you will succeed. We have Association of Nurses, nurse executives in India, which was brought a few years back. My good, friend, Tangam Gomez, madam, she's president of Association of Nurses Executives of India. And the vice president, Dr. Jyoti Kalara, I think most of the people you might have heard about these two leaders in country. They thought about it and they have brought up an association. They have organized many Empower Arts for the nurse leaders in India. And their main aim and vision of this association is that nurses lead healthcare. It does not remain in slogans, but it becomes reality. It looks challenging, but it is not impossible. Now we have a Niti Aayog, Atal Innovation Center, where it has a 6th domain aim, and that is there is a thinking lab, there is a incubation center, there is a new challenge competitions are organized, and there's a committee innovation center, and there's a research innovation small entrepreneur and startup center, and mentor change center, where they are supporting the people who are thinking about a new idea and innovations and patenting. So primary purpose and mission is promoting culture and entrepreneurship and innovations in India by Atal Mission. It is not restricted that nurses can't make use of it. Probably we have no evidence. I request participants to mute yourself. Otherwise, we will be defeated in achieving our objectives. Thank you. So primary purpose is promoting a culture for entrepreneurship and innovations in India, and nurses are welcome, but they must make use of it. And 4 major objectives are to provide platform and collaboration opportunities for different stakeholders, to develop new programs and policies in different sectors of economy, to create an umbrella structure for overseas innovation ecosystem for the country, to create awareness and provide knowledge inputs in creating innovation challenges and funding mechanism by the government to the people who want to do innovations and patenting. If we have intellectual property India, this is basically where you can file your patent. Nurses have done a lot of contribution into ideas of Indian jugards, which they themselves, if know the pathway of how to do a patent and then transfer their patent to industry for product management, they can earn a lot of financial dividends and recognition out of it. I think Dr. L. Gopichandran, being president of TNI Delhi chapter, will take another series of lecture how to do a patenting of the ideas. Nowadays, the technology is changing the life of the people, and a lot of apps are coming which are making life very easy. There are health apps which can make a huge changes, and nurses can contribute hugely into it, and you can patent them. You can really make a change into the way people access the health and the way people make use of the health considerations, where, you know, if I give an example, a patient getting discharged with a stroke, and he's getting discharged with few requirements to be taken care by a family member, and family member knows how I need to feed this patient, how I should prevent the bad sores in this patient. If his patient is discharged with catheter, how I can take care of a catheter so that the patient does not develop UTI. When this catheter need to be changed, an app is developed and it is handed over. The family member can train themselves to take care for this patient. There could be many more such examples of apps. These apps can be patented. They will not only make the life easy for the people, but they will also give you earning of a dividend in reference of royalty as a money. There are two things: entrepreneur and intrapreneur. Intrapreneur, that you are employed somewhere with help of an organization. You are, patenting your ideas. You are doing copywriting of your intellectual property, and finally you are transferring this to industry to earn the dividends. So here you are earning recognition and you are earning money, but meanwhile you're employed with help of your organization, and it could be shared with your organization where there's a less risk, because you are already employed, you're earning salary, and then you are creating ideas and transferring it to the industry. Whereas an intrapreneur, you're taking risk. You are taking your own idea to convert it as a business, and you go to B2B model or B2C model and enter into market for selling your idea or product. So you can, at least businesses can start with being intrapreneur, and then some of we can have a courage to be entrepreneur. There are international organizations like National Nurses Business Association or American Organization for Nurses Leadership. They hugely support the nurses who want to be entrepreneur, because they not only bring green pasture for self, but they also significantly contribute into the economy of country. Last year, they had a conference where their theme was strategies, tactics, connections, leadership, wisdom. And in 2022, again in September, they are having conference, and they say nurses to lead the future health challenges. There are 6 core pillars for effective entrepreneurial ecosystem in any organization or any country. That is accessible market, human capital education, funding and finance, support system and mentors, and government regulatory framework and cultural support. I have given you example through Atal Mission. Government is trying to create that ecosystem, that we have more ideas, we have more entrepreneurs, we have more Make in India initiatives rather than buying everything from the West or other countries for healthcare system. And I think nurses can hugely contribute, because they spend a lot of time with patients. They can have a lot of ideas. So not let these sperms die or ovaries die, but they get converted into tomorrow's babies as a product. And healthcare industry of India utilize these cost-effective products and make a huge difference. The building economy of the country and having the Indian essence product which makes a difference into the health of the people. So to summarize, there is a growing scope of entrepreneurship for nurses in India. They require passion, patience, creativity, hard work, business skills like accounting, marketing, sales, developing customer base. Nurses can take an independent nurse practice, home care nursing, medical device manufacturing, sales, industry, consultation, tutoring, nursing education, writing, publishing, blogging, career advice, placements, and many more such things of being an entrepreneur. Thank you so much for listening me patiently. If you have any questions as a model of this webinar, I will be happy to answer them. Once again, thank you all the organizers for giving me this opportunity to speak to this August gathering. Thank you.
Thank you so much, sir. Thank you so much for this interesting session, which I think every nurse must know, those who wanted to do something different in their profession. I'm Dolma. I'm sorry for my video because my system doesn't have a video. So, sir, just to summarize what sir has taken today, sir has first create the importance of developing a new generation of nurse entrepreneurship. Sir has raised concern on the young energetic brain must take ownership of the entrepreneurship, which we have been doing, but then we have not been recognizing it as an entrepreneurship. So initially sir has talked about nurse entrepreneur as the combination of passion, skill and nursing, which requires creativity, hard work and business skills. Sir also has taken us with the clinical scopes and academic scopes as a nurse entrepreneurship, where in clinical scope, there is independent service provision, home care nursing, health and medical devices, and then industry consultation also. And in this, sir has raised concern on the importance of patenting a product. And once we patent the products, it will be cost effective, customized to Indian population. And in the academic scope, sir has talked about tutoring, writing, blogging, and career advice placement. Sir also has taken put efforts in trying to make people understand that the path to entrepreneurship is first for getting a success, we need to do it first, and do it. You may fail, but then do it again and try to keep doing it, so success will be achieved. And sir also has sensitized us about the government initiatives by Niti Aayog regarding Atal innovation mission. Sir actually requested also the president of TNAI Delhi branch regarding the patenting, the pathway to patenting. Sir also has given us the importance of it, but then sir also raised concern that need for a complete session on patenting for nurses also. So sir will think over it, and we may need your guidance also on this in a future session. In the later part of sir's session, he has taken about the difference between the entrepreneurship and intrapreneurship, and he has said that nurses can start with intrapreneurship, then can go for entrepreneurship also. Then sir has also sensitized about the international organizations who supports nursing entrepreneurship. Sir, thank you so much, and we would request you to be here till the next session, because the question and answer session, if we have, will be after next session. So sir,
Sure.
we'll request you to be here. So next I'll hand over the screen to Bindu ma'am to introduce the next speaker.
Well, good afternoon, everybody. I hope all of you are enjoying the session. We have yet another eminent speaker with us for our next session. That is Madam Deepa Achu. She has an intermix of skills in the various fields like the clinical nursing, research, as well as administration. Currently, she is working as a head of nursing services at the National Heart Institute, New Delhi. Being a certified NABH assessor, her main interest is in the quality control and has also contributed a lot towards this area. And she has worked as a quality control officer at Wadia Hospital in Mumbai. She's an expert and a resource person. Her specialty area is cardiovascular, thoracic, and vascular nursing. And she has presented various papers under this umbrella in national as well as international forums, as well as published papers in journals of repute. Among her accolades are, she's a gold medalist in MPhil nursing from Manipal University. She was awarded the Excellence in Nursing Care Award at Wadia Hospital in the year 2014. We are really glad to have you, ma'am, here for this session. Over to you, ma'am, for your session. Thank you, ma'am.
Thank you, and a warm afternoon to one and all present here. I, first of all, like to thank the President, Dr. Roy, Dr. Annie, who I met for the first time, but ma'am, I was wanting to meet you, though on personal note, but well, we have to accept what presently we are through. Dr. Gopi Chandran, it was a pleasure meeting you in the past, as well as after that we have been associated. It's my pleasure that I'm associated with eminent personalities. Madam Bindu, Madam Dolma, Madam Shaini have been working behind the screens, and there are other empowered leaders who have been behind the screen. Kindly accept my sincere gratitude for working for such a noble cause. My special thanks goes to Dr. Sharma. And sir, I would say that you have opened up the Pandora for Shark Tank nursing. So it's one of the important area where today nurses have to think of. It's though late, but well, always it's a chance. The next 20 minutes have been given to me, and I just would like to share my screen. A moment, please. Something went wrong. I am not able to share. Have you all given me the rights to do so?
Yes, ma'am. You are the co-host. Mr. Prashant, are you there?
Ma'am, it's coming up.
It's coming?
Yeah. Yes, ma'am.
Yes,
Can you put on the first slide, ma'am?
Yes, ma'am.
Yeah. Okay. So the next
Yes,
20
yes,
minutes,
ma'am,
I
you can
will be
see.
speaking regarding recent advances in clinical nursing practice, though it's a wide topic, and every topic, subtopic which I would be speaking about would have its own topic too. So Dr. Gopi Chandran can take a note that these are the areas where we need to actually make our future nurses ready. And also the present nurses should have clinical knowledge into all these areas. Well, I would try to touch all the areas possible. The main emphasis I would try to. When I say, sorry, yeah, when I am looking at advances, I'm not going to talk about breakthrough in some chemical reaction, some major surgery, or becoming Aryabhat. We are looking at certain small kind of innovations which our nurses are doing day to day. The Indian Jugaad, as rightly said by Dr. Sharma. But the thing is that, very rightly said again, that the patency is missing to it, as well as we consider it as it's my job to do it, but we do not realize that these small elements of innovations are what are we looking at advances in nursing. We are not going to look at major things. We at nursing levels are doing every day to day, we are doing it. So we need to project it out. In today's time, it is said, jo dikhta hai, wo bikhta hai. So we need to bring it out, show it to the world that we can definitely do it. And we have done it in the past. So we are just going to talk about what all changes we are been doing and the small elements of nursing innovations. Just to brief you all of the past, that these are few leaders of our nursing fraternity, where starting from definitely our mother, Florence Nightingale, that the hygiene theory which she brought about. There are others who are unsung heroes, like Bessie Griffin, who has founded the feeding tube, and probably few of us only know that she was the one who invented it. Sister Jean Watt, who started with neonatal phototherapy, Anita Dorr, who invented the crash cart, the Barton sisters, who started with the color-coded IV sets, and Naomi Bennett, she was the one who started with Neo Slips. I have a request to my academic colleagues who are in the forum that if you go to medical colleges, you see photos of Robert Cox, you see Dr. Paul, Dr. Ronald Ross. I fail to go to any college where I see Sister Jean Watt's photograph with the phototherapy unit. I fail to see Anita Dorr's photograph where the crash cart is there, which we are using in every area of our hospital today. So we have failed to project ourselves. We have forgotten these unsung heroes, and this is the right time we remember them. That, okay, we were late enough, but yes, we will try and bring it. These are the people we have to bring forward amongst our Generation Z, so that they can feel that, yes, they feel proud about it, that they are the ones who are the ones who can do better and even bring in changes in our field. Going forward, so the main thing which we are looking at is thinking out of the box. And this is what the Generation Z wants us to teach them. How can we do that? The best method in today's time, gone are the days when we say nursing practice needs to be highlighted. Nursing practice should be utmost. Today, we need to think of the Generation Z and the millennials who are working with us. They are different than what the kind of Generation X people are, or the baby boomers. They want more and more technology. They want more and things to be a little more easy doing. They do not want hard work, they want smart work. And how can it be done is by inculcating the method of praxis. Praxis is nothing but the knowledge and the practice which we, the Generation X, used to do it, but incorporating research, incorporating entrepreneurship into it, making it praxis. So today the Gen Z look forward for praxis, and that is how we will look forward for more and more innovations, and we look forward for more and more advances coming in. What we at the present time, which we are using in day-to-day activities, you all know that we have spoken a lot about evidence-based practice. But are we actually bringing it at the bedside? The main aim of evidence-based practice was to bring it to the patient, bring it to the bedside. But there are very, very few number of nursing leaders who have brought evidence-based practice at the bedside. Few amongst us which we have been using, and many of the other hospitals have also started using. I have just exclusively put whatever we are using in our practice, though there are so many others, but these are the highlighting ones. For CABG patients, when we use the saphenous venous graft, they get swelling as well as their parameters fluctuate post-operative. So foot massage, if it has been seen that the edema reduces, the hemodynamic parameters come to normal. So this is a kind of evidence-based practice which we have seen, and we are practicing it, comes out really wonderful results. The second one which we started with was the toothbrush, use of toothbrush instead of the artery forceps. Though today's time we have a lot of brushes available along with a suction tip, but they cost huge. And every patient who coming to the hospital may not look, it may not be possible for them to have such lot of funding, be it from their family or be it from any category or from the insurance companies. So using a normal toothbrush to the ventilated patients, to the intubated patients have worked wonders. We have had microbiological examinations also done for these, and it has worked wonders. Music therapy, I think nowadays almost everyone is using, and we have realized that it works wonders not only for the patients but also for us. The Berger-Allen exercises, which we are doing it for our PTCA patients, have worked wonders, and it has become a norm now. Everyone knows what they have to do and how they are supposed to be doing. The we had seen that the dialysis patients who were there with us, they used to complain of muscle cramps, especially the calf muscle cramps. So we started doing one small experiment with these patients, that is leg exercises, moist heat, as well as ginger powder. The best which we came out with was the moist heat, and now it has become a norm in our dialysis unit that we are using these towels, the warm heat towels around the calf muscles to give relief to the patients. It does not have 100% relief, but yes, I can assure you that 80% of the muscle cramps have reduced. The ginger powder, though, was used as a muscle relaxant. It did not work as a muscle relaxant for the calf muscle, but it worked wonders in the GI tract. Patients who were suffering with constipation have given wonderful results with ginger powder. And we are also using, because we have a huge load of COPD patients, so we use 5 postures which give them comfort. So these are few things which we are using, and I'm sure every hospital in today's time where you have leaders who are into they are educated, they are into evidence-based practice, they are doing good quality work, you will find a lot of these researchers coming in. Also, I would like to highlight that many of the hospitals now are coming up with the library. The library, please do not consider it that it is only the medical students or the doctors who are supposed to be reading it. A library should be having nursing books, and there are hospitals who have very good nursing libraries, especially emphasizing into journals. Another breakthrough which today's time we all are using, and it has become a mandate as per the standards of NABH, is the critical pathways. Critical pathways, you say care pathways, you can call it as clinical pathways. They are nothing but care maps. They can be used for patients whom we anticipate, okay, say if a patient is coming from, has undergone a CABG. So I know that on day 1, this would happen. The patient would come with these lines. This is the set of investigations I'm supposed to be doing as a nurse, as well as the day 2, what I'm supposed to do, day 3, what I'm supposed to do. The dietitian would know. So it is just a mapping of these. This itself is a huge topic for teaching as well as to implement it, but I'm just touching some areas for future elaborations. Now, this would basically provide standardization of care so that every patient gets the same equal kind of quality care which the institution is looking at. It will make the processes in line. It would make your resources, appropriate use of resources, and reduce the cost. Today's time, we nurses have to think of the cost, because not only in perspective of the hospital, also in perspective of the patient. It is hard-earned money of every individual in our country, and we definitely work really hard for it, be it your money, be it anyone's money. So cost becomes a major factor today's time, and unnecessary things should not be used. So when we use these clinical pathways, the use of unnecessary investigations reduces, unnecessary, the indwelling time of the catheters reduces, the patient becomes better recovered. Improve quality of care, definitely, and change practice patterns to increased efficiency. Everyone in the unit, they know what is their job, how they are supposed to be doing what they have to. It's a multidisciplinary service and a sense of satisfaction, not only for the patient, but also to the people who are working. I'll give you a small example of hip arthroplasty clinical pathway. So this is something like on day 1, what all things are to be done, by whom, what all investigations we are supposed to be doing. Say for if you go and see in the investigations, it is the post-hip X-ray performed. So whether it was performed at the AM time or the PM time, you just have to tick in. So it becomes very easy for the nurses. It does not remain too much meticulous into writing work and maintaining too many records. A single record can be used for the entire team. So the doctors can write it, the nurses can write it. You see there is pain management, you see there are treatments which are written over there. So they just have to tick it whether it was done or it is not done. If it is not done, they would definitely have a reason for it, of not doing it. But Everything is mentioned so that you are not missing. Even a fall risk assessment is mentioned so that you do not, nothing skips off the head. When nurses are working at the bedside, you would not imagine the kind of mental load. We have already spoken about a lot of workload, but the mental load which they are having for each patient. And like that, they take at times 6 patients, at times 8 patients, or maybe more. What kind of load they would be having, and to slip things during that time is very, very convenient, and it can happen with you and me. Put ourselves in their shoes. We would do it, and we all have experience. We all have worked at bedsides, so we know that. If you see, the nutrition aspect is also taken care. The patient education is also taken care. From day one, we start with the discharge planning. So every element, if you're using a clinical pathway, cannot be missed. So it's a perfection towards the best of the quality you can provide to your patients. But definitely it cannot be used for every patient. It may not be possible for using for patients who are brought up in the emergency department. It can be used very efficiently for post-operative patients. It can be used for patients like if the patient comes with a ST elevation MI or an NST MI, things like that, it can work up, It can work up. So now again, the same day 2 starts. So what all things should be there in day 2? And you can see the format is very, very simple format for anyone to follow. So such kind of formats, and believe it, these are made by the nurses. But again, we have not shown the world that we are doing this. We fail to show it. And the patency becomes of some other person. They start selling it. So this is again one area where you can work up with a lot of clinical pathways. You can have your patency and try making a business out of this also, because this is slowly coming up. And there are other people who are non-medical people who are doing all these things in today's time. So wake up, nurses. Another area very important, again, nursing audit. I'm sure all of you all today's time, we are learning, starting from the BSc nursing. We are starting with the element of nursing audit. Why it is important is because there are lots of gaps when we work. Jahan kaam hota hai, wahan par gaps aayenge. So whenever we find any gap, I need to find out, where am I going wrong? What is happening? And I just cannot do it. I saw one person giving, say, a rise to feed without maintaining a good posture of the patient. That does not mean that everyone else is doing it. But if I see it repetitively when I go in rounds, then maybe yes, that's an area of gap. Say if I see any nurse while in my regular rounds that they haven't had good hand hygiene before manipulating the central line of the patient, or if we have got 2 consecutive central line infections in 1 month, then that becomes a gap, and we definitely need to do an audit on it. Now, as an audit, we require to identify where we are having the gap. Hence, we should be having a topic for it. We need to have a standard which we need to select. The data should be collected accordingly. That and that data cannot be just collected. We should be following all the norms of sample size calculation. So the norms of sample size calculation, once it is done, you need to collect your data. So it's a kind of a research, but I would not say it's an elaborate one. It's a small one, and there is no use of statistics much. We can just keep it very simple as frequencies and percentages, so that we come to a conclusion. Say, for example, the replacement of essential medications in your crash cart. You witnessed one of the crash happening, and you found that the basic medication, say soda bicarb, was not available, or it was only 1 was there, whereas the norm says it should be having 3. So there was a gap, and even of 1 single gap, the importance is very major. Impact is high impact. So you need to find out how many of such things were happening, who did not replace the medications, what happened, and then you do it across the hospital and find out where was the gap. And thereafter, once you bridge the gap, you have to re-audit it. Once you have done the re-audit, now it becomes a process for you. Now it should come as a policy in your nursing manual. So these are the methods by which we are now bringing in slow but steady changes in our clinical practice and making nursing as the best quality team. Every hospital looks forward for getting the best patient satisfaction, or I should say today's time, we're not even looking for patient satisfaction. We look forward for patient delight. This beyond satisfaction. So if you aim there, nursing audits works wonders. Another method which not only satisfies the patient, but also satisfies as me as a nurse. I remember I also cribbed when my in charges used to give 5 patients to me, or 3 patients or 4 patients in the ICU. And ex-colleague of mine is just getting 2 patients and I'm getting 4 patients. So that conflict would always remain. And probably, I'm sure all of you all must be experiencing that with your co-workers also, that they are dissatisfied. They feel that I am overburdened, some X-person is not. Equity-based nursing assignments have solved this problem completely. This is again a staffing pattern which provides consistent and high quality while you are making sure that the cost is very less. Now, how do you do that? Is again equity-based. Again, would require a lot of practice for doing it, because it would require the in charges or the team leaders to be really competent on it. Good assessment skills would be required. Once it is in practice, after 4, 5 months, 6 months, it becomes a norm and everyone is satisfied. The management is satisfied because the cost comes out to be low. The nurse is satisfied because it is equally distributed and it is evidence-based. And the patients are satisfied because the needs are being met. Now, how it has been done is you categorize or you assess the patient as stable, as 1, 2, 3, 4. This all depends upon the scoring. Now, the scorings are depending upon the assessment of the patient, the hemodynamic parameters, the medications, the indwelling catheters they are having, and the kind of pain they are experiencing. If they're having dressings, there are many other points which are to be looked into. I've just given you a brief one, but it has an elaborated extension of this also. So once you identify, say if my patient is a complex patient, he's having chest tube drainage, he's having feeding tube. So I cannot be taking care of 4 such patients. So my nurse in charge would be, again, there is a mechanism by which you need to calculate. The in charge calculates and informs that how much patients, the ratio, the nurse patient ratio. One of the days where somebody has made it that, okay, in the ward it is 1:8 or 1:6. Probably if I see in my hospital, I will not be able to give that much pressure to my nurses, because even patients with feeding tubes, even patients with chest tubes and everything are there in the wards. So it's impossible for them to work as per the protocol made by accreditation body or by our councils and everything. So we need to come up, and this is one mechanism where people are satisfied. And with this, you can justify to your management also that why do you require these many nurses? This is a big question we all are facing as leaders. Attrition, we go on talking, then we go on talking about too much pressure to the nurses, workload is high. We'll be able to justify why are we asking so many nurses. So this is one mechanism or the advances which in the clinical practice we are doing and has come out wonders. Today's time, everyone says because of the accreditation bodies, because of too much of accreditation, say it by the national level or international accreditation bodies, we are writing. Nurses are busy writing. These are the complaints from all our team members. But we need to understand that one NABH standard does not mean one form. You need to bring down, the nurse leader who is sitting needs to be formulating the documentation in a lean and a narrow method. Size 0 is the norm today's time. So we need to even bring our documents to size 0. We cannot have bulky documents. We can, I just give you an example. Visiting many hospitals, you have fall risk assessment, you have the entire Morse fall risk scale, written everything on it. Why do we need that? Why do we need that? Why do I need the entire GCS to be presented in the form of a chart? Why my mental abilities are not there? Why my nurses are not intellectually capable of remembering things? How many scales do we have? 8, 6, 10, how many? So am I not going to just write the scoring? Am I not having that much mental maths? So why am I supposed to have every element of the Morse fall scale? And then I write 1 + 2 + 3 + 4. There's no requirement of such. I can just write one single number and say, okay, my score for the fall risk of this X patient is this much. So you have to work up in those methods to make your nurses more intellectually intelligent. If you feel so, if it is not possible, have charts available for the reference in the ward or in the ICUs everywhere. You just frame it and put it. They would look neat. They'll have a ready reference, and you will not have bulky documents that every place they have to write 1, 1, 1, 1, and at the end they will calculate it and write it 6. This is not what any standard, any accreditation body tells you, but it is the nurse leader who understands it that way. So my request to everyone, make it as lean as possible, make it lean, then make it size 0. Start making nurses notes by exception, not patient is hemodynamically stable, this. When patient is hemodynamically stable, I need not write everything. I have to write what is not stable. So it is charting by exception. Another method for making our nursing care plans a little more easier for any regular nurse or a novice nurse also to come and do it is data, action, and response. So you just have to put your data, what was your action for that data means the assessment part of it, what was the action which you have done, and what is the response of it, making it a little more narrow, making it a little more simpler for the novice nurses to start up their, the profession. Nursing competencies are really looked at a very, very larger scale in today's time. In all the sectors, I would say, the public sector, be it your private sector, because everything, your performance appraisals are based on your nursing competencies. So maybe I have my TLs who are just 1.5 years experience, but they're working as TLs because they were capable. They were good in their competencies. So gone are the days where we have to look at the number of years of experience. Okay, this is, I need 10 years, then only you can become in charge. I have an in charge who is 3 years old. I'm in 3 years in nursing. So she's competent and she has performed excellent. So today's world, we are looking at competencies. Competencies are not only for performance appraisals, they are also used for induction trainings. They're also used for nursing training, CNEs, which we are conducting weeklies. So this again is a topic by itself, but to just brief and go forward, all of y'all, I'm sure, has undergone the theory of all this. Major element of nursing today, which everyone should talk about and has worked wonders. People are working as consultants exclusively for nursing quality, and they are nothing but your dashboard. Now, medical field is a kind of a field where you cannot put it on paper that out of 100 I scale at 70, I scale at 75. You cannot do that. You can have parameters of quality so that I can say, okay, I have ranked this much, or I am up to this level. Beyond this, there is no report card available. So this is my report card, the nursing quality indicators. A lot of quality indicators today we are working with, patient-related quality indicators, operational indicators. Few to emphasize are the patient falls, bed sore, medication errors, phlebitis, accidental declining, delayed initiation of CPR, infections, patient satisfaction with pain management. Operational kinds are needle stick injuries, the satisfaction index, and many more. Today's time, the 5th edition of NABH is also talking about you creating your own departmental quality indicators. So gone again are the days where you should have one single list of indicators. We now require to further go deeper into quality and find out, say if I have a cath lab, so the door to balloon time, or I would say door does not mean the door of my hospital. I would call it the door of the home. So it depends what you want to create, which level you want to go. So you need to elaborate your intellects into that area. You need to read a lot. You need to find out what others are doing, and there's no harm in learning from this. If some ex-hospital is doing, please propagate it. Becho apne aap ko. Sell it out. Show the world what you're doing it. Even if I have 6 falls in a month, so what? Let me write it. Let me understand where am I going to. So this is the way how we'll improve it. And how it's not only data collection. Quality indicators is not that someone will just say, okay, I have 6 falls in a month and 2 needle stick injuries and 5 medication errors. No, it's not like that. You need to work up with the quality tools, how it has happened, why it happened, how you are going to bridge this, and how you would work up in a preventive way. That is, that this thing should not happen in the future. Well, it would always happen. You will have corrective actions, you'll have preventive actions, still you will have needle stick injuries. It's fine, it's acceptable. So recently I was studying an article that the JCI has given statement which says that 72% of the medical errors happen due to communication errors. Huge things to look at. So do you think that they are not working towards quality? They are also working towards quality, but it's an ongoing process. It's a cycle. You go on closing one, the other end opens up. But at least we are working towards it. We are closing some doors to let the others open. So you have certain mechanisms, certain tools which you can use. A few of the ones which I have depicted, you have 100 odds, but a few to highlight is the PDCA cycle, that is plan, do, check and act. You have the Kaizen cycle, again a famous tool which today's quality data we are measuring through that. The Pareto chart, which in nursing research also I've seen many of the journals, they have come up with nursing researchers using the Pareto chart. The fishbone, again a common one but very effective mechanism by which you can find out where did me go wrong, or me in the sense I do not say only me, I mean my entire process, because it is never the individual who goes wrong, it is always the process which goes wrong. So we need to work up a lot on the process, and this is what the today's academics should emphasize on. They have to be groomed in a mechanism that when they come out, they are already knowing all these things. They can be empowered to take positions. Today, we have to train our nurses 4, 5, 6, 8 years as per the capacities and as per their competencies. Then they come up to the level where they can take up these, these kind of
Sorry
tasks.
to interrupt you, ma'am.
Over. Yeah, I'm done. I had kept a track of it. I know I took few minutes extra, but this is just a chance for every one of us to change. So that's from my side. And I would love if someone has any kind of queries, it would be my pleasure to solve.
Thank you so much, ma'am. Thank you, Deepa ma'am. So ma'am started her session by echoing the concern of Dr. Sharma regarding the day-to-day jugars of Indian nurses must be out in the market by patenting. So point well taken, ma'am. We would see some of the sessions in future as suggested by Dr. Sharma as well as your concern. So we'll of course get back to all the nursing leaders who are into this patenting and all. So that is one thing. And ma'am has started by raising concerns about the nurse innovators whom we are not recognizing, like be it the hygiene protocol, the crash card, or the feeding tube, or color-coded IV lens, etc. So we'll have to recognize our own nurses' work by the nurses. That is one thing. So then ma'am has said regarding these innovations and thinking out of box by a praxis method, and which is the combination of knowledge, research, and practice. And though we talk about evidence practice, ma'am has also rightly raised concern that very few bring it to the bedside. So the link is missing. Ma'am has given some of the very pertinent examples of how they are doing it. Next is the importance of care pathway in providing quality of care by standardization of care process. That also ma'am has given a very detailed example. Then regarding the nursing audit also, ma'am has given bringing change and improving patient satisfaction, how important nursing audit is. That also ma'am has given very, very pertinent and practical examples. Another method, equity-based nursing assignment, how she has also explained how this equity-based staffing leads to satisfied managers, satisfied staff, and satisfied patients. Uh, Next, ma'am's point was lean documentation, where the nurse leaders must use lean documentation and do away with the things which they don't need actually by using like CBE and DAR method. Uh, mm, Next, ma'am talked about nursing competencies. We must give responsibilities as per competencies. And in the era of accreditation, there is need of nursing quality indicators, and we must use the nursing tools. When we have the indicators, then we need to use nursing tools and try to see how we can bring change and improve patients' experience yeah, of the services. Thank you so much, ma'am. Now we'll go to the questions if we have. There was one question for Deepa, ma'am, I think, by Shubhangi. Ma'am, I asked one question on muscle cramps in dialysis patient, how to apply ginger powder. That's Shubhangi's question to Deepa,
Actually,
ma'am.
this one of my students had done one research study on this. It's a MSc research study where we saw that dialysis patients have muscle cramps. So after a lot of review of literature, we found out that we can use certain things. One is just take towels, put it in hot water, squeeze it, put it around the calf muscle area, making sure that your bed does not get with a Macintosh and everything. And this can be repeated. So in the dialysis unit, even patient relatives come, so we can give hot water available to them. As the students got over with the study, now we have even told our patients that you patient relatives can also do it simultaneously because they are sitting ideal. So they should be incorporated in the patient's care. So that is how we are doing with our calf muscle moist heat. Ginger powder, it can be just taken as per the wish of the patient. Some people prefer to put it in the warm water and just gulp it in, or just a powder can be taken, half teaspoon of powder, and with just water, plain water. That's it. But it did not show much results, but it has shown good results on constipation, relieving constipation. So that was, we had put that point in our discussion that though it was not effective much into reducing calf muscle relaxation, but it worked wonders with relieving constipation. So that's again one area where people can explore into.
Yes, ma'am. So these things are very innovative way in providing comfort care. But ma'am, what is your suggestion? Like how, for example, in a government sector where the culture is not there of innovation, so how to start if somebody like some young nurses, they really want to do something which is evidence based, but it's not in the culture. So what do you have to, advise them or say, like, what is your thought on that, ma'am? Situation like that, the hospital who have,
Ma'am,
yeah, culture is okay. Yes, yes.
I do understand the ratio, the nurse patient ratio is very high in the government sector. But say, for example, even the moist heat to apply it in the on the legs of the patient during dialysis, I don't think any nurse would require any permission to do so. And this is something which can be done at a personal note. And she can simultaneously, we fail to collect data. Even I'm not blaming it on other. I see so many patients over here, and believe me, when the doctors, they come up with when we have monthly case presentations, when they come up with a particular case, then I realize it, oh wow, this was a very good case and we missed on to it. Why didn't we went in for this case study?
Yeah.
So we need to learn, we need to understand that we are more engrossed in only care. We are not engrossed in research. We're not also having that, that vision should be there, that I need to look also simultaneously. I don't have to do a special round for doing a research. But in my day-to-day rounds, in my day-to-day nursing practice, clinical practice, if I'm working as a nurse at bedside, there are so many, one more method which my nurses use it, and that is my nurses, they told me that this is what they have come up with. We had grade 3 bed sore coming from outside, and they recovered it. We had a party in that clinical area because it was unbelievable changes. What they said is, we just use dry oxygen And I was surprised. I said, why did you make some notes on it or anything? They said, no, we just used to use dry oxygen every 2 hourly and it has worked wonders. Believe me, it was absolutely zero. So
Hearing for the first time, ma'am. It's so nice to hear something like that.
Yes, and it's only we have to talk to them. How did you do so? And it was a learning to me. And I think there should be some nurses who are interested in doing research. Please, I would also love to do it. Short of hands right now, but I have kept this point that I would love to do this research because oxygen, dry oxygen, and she told me, ma'am, moist oxygen se kaam nahi hoga, because it would give, it will keep the area more moist. So we used dry oxygen. So, these all things do not require any special equipment, does not require special training. Like the Berger-Allen exercises post PTCA. We have seen wonders happening over there because usually when the femoral site is used, there is a chances of hematoma because of the movement. We had drastical reduction in hematomas, and even discolorations were reduced because of the Berger-Allen exercises. But whereas if you see the Berger-Allen exercises started with diabetic foot, the main exercises for diabetes, we used it for PTCA, it worked. So these
so the clinical nurses, they need to have confidence actually to carry out.
And they need to read. They need to read. I have a wonderful library. Believe me, I personally tell that I have to give assignments to my nurses to go to the library. I do that.
These days, ma'am, information is everywhere. There are lots of information on your fingertip. But yeah, we need to read. We need to have
Google Swami, but not always help.
No.
There should be a culture. There should be a culture of reading journals. There should be journal presentations more at the bedside, case presentations more at the bedside. So this is how the nurses would improve. Gone are the days where we should have CNEs. I have only once a week. I do everything at the bedside. I just have abolished all these things over a period of time. I said, no, we do not require a classroom where 40 nurses will come and sit and they will not learn anything. What I want, that was the time when at the BSc or the GNM level, they have to learn and come. When in the clinical area, it has to be bedside. It has to be 100% bedside. If they are in the ICU, I have to take a class in the ICU. And that too at the bedside just for 15 to 20 minutes. So it should be an ongoing process. And for that, I know no one need to take permission from any organization. And if we have to take permission from any organization, I think we are working in a wrong organization.
So the nurse educators and the nurse infection control nurses, if they are in this room, please take note of it. Clinical bedside teachings, you should develop a culture of clinical bedside teaching and then see what difference you can make. Thank you so much, ma'am, for this point. So another question is from Dr. Vaneja, saying how about ISBAR for communication between nurse? ISBAR ke baare mein.
I read that, but as ISBAR is now become a routine, so purposely I have not used that because it's been a decade now that we are using ISBAR method for communication, be it for endorsement or be it for telephonic communication or any kind of medical communications which we are having. So this would probably at the present time, I felt that it should not be included in the recent advances because it's a generation, a generation of people have been doing so, but point well taken that yes, ISBAR, if any organization is not using, this is again one thing which we nurses are using, and believe me, it is only the nurses who are using it, and proudly to feel that it's only the nurses who are using. Go to any accredited hospital in the country, including JCI accredited hospital, doctors or the paramedicals or physiotherapists, nutritionists, no one is using except the nurses. So feel proud about it, propagate that yes, this is my team who is using this mechanism and no one else.
Thank you so much, ma'am. I also agree with you. So I think no more questions, I think. My question, okay. From
There is one
Kritesh.
question.
Yeah. Where we will get guideline how to start home care nursing agencies. This is for Dr. Suresh. Sir, are you there around?
Yes, I'm right there, Dharma.
Yes, sir. Did you see the question?
Yes, I see. It's Kirtesh Patidar is asking this question. I'm happy to answer. Home care nursing clearly falls into the domain of nursing care. And there is no defined guidelines. You need to structure your own scope of home care nurse which you would like to offer. You may be interested in offering only geriatric home care. You may be, offering home care for postnatal people or maybe for the newborn children. You need to define your scope. You need to define your own SOPs based on based evidences, because you are going to sell this into the market, whatever best which suits to your customers and whatever is beneficial for them, they are going to buy this. And to structure is to start, it does not fall into Clinical Establishment Act definition. So you can start it and you can start providing it. Now, way to register it. You can register into different registering system which are prevalent into different states. Maybe a SOP registration which is happening, probably that may be initially sufficient. And then if you're expanding your scope, then there are definitions like if you're employing less than 20 people in an organization, you may not require a registration for a healthcare center. If you're expanding it more, then definitely you have to register into healthcare center registration system, which any nursing home or healthcare center which is open, different states have different registration system under the healthcare authorities. And you just run it. And once you start earning dividends, you are into market, you will learn more. I hope I could answer your question, Kirtesh.
Yes, sir. So the financial part of it, sir?
Financial part of it is you need to define how much you are going to charge for each service or duration of service, and who are your care providers. You may be having some of the care done by the clinical nurse assistant or the home care nurse assistants to whom you are training and you are utilizing them. Or maybe you are employing nurses or auxiliary nurses or registered nurses, and they are offering those services. For example, if you're offering services for the post-stroke and elderly patients, I have seen somebody is offering in Mumbai, and they have trained their people of certified nurse assistant kind of people who are assistant to them. They did a training for them, and now they have a network. If somebody is asking, they go and care for them, and these includes like bathing, changing, feeding, and nasogastric feeding and catheter care, perineal care and stuff. And then for duration of hours, they charge for them. There are nursing cares like where you require auxiliary nurse or registered nurse who are licensed one, like administration of medications, intravascular or intravenous or fluid administration. In that case, the certified people go and make a visit and then do it. So services could be task, such charges could be task-based charges where a registered nurse going and then doing a dressing for bad sore and infusing a medicine or administering a medicine, or a care assistance doing it. So based on that, you can define your charges which you feel that customers can pay. And it depends on the way you are located. If you're in metros, people may be affording more charges, and if you are into category B cities, they may be paying you less. So wherever you are, but home care nursing is taking up hugely now. And public education is another entrepreneur which is taking hugely now. People, you may be developing a website where you are hosting an Indian customized education for them, for like we used to have dadis in their families now, before. And they used to advise, if this is there, you take this. And if you would like to, have evidences and evidence-based SOPs you would like to give for people to, use at home itself, or maybe you start, selling these natural products, and you also have these products available into different cities. And this is also picking up hugely as a market in India. So nurses has to take a lead, has to think about it, take up challenge. And I tell you, when you start up something, there are challenges, but if it happens, it creates a huge difference. Like I'm patenting now a molecule based on an Indian spice. I'm facing a lot of challenges by people, but yes, we started a journey. We went to Naipur, where in Naipur I had a professor from natural products partnered with us. We have extracted a compound out of it, and now we are patenting a compound. And I tell you, if it works, it's going to create a huge echo, not only in India, but whole globe about diabetes. And being a nurse, there were many challenges. People challenged me that you can't do it, but still I'm taking it ahead. And I think probably it will see the day of light. So we need to just start thinking, and it works if we are determined, if we have patience and passion for it. Thank you so much.
Exactly, sir. You can do it, sir. We are very much sure that you can do it. All the very best, sir.
Thank
All
you
the
so
very
much.
best. So, sir, it's always very nice to hear you always. But then, yeah, every day we can't listen to you because you are also very, very busy. We know. Now, just a take-home message, sir, if you have to our audience. Any take-home message you wanted to, just to motivate them.
Thank you so much, Madam Dolma, for your kind words. I'll just say one thing to every one of us. We must respect self as an individual and nurse. We have a peculiar problem in India. We value our other colleagues more than self. No one is less than anyone. The day we will start respecting self and believing on self, and we will start living with our passion and dreams, I think this change will start happening. In India, nurses have lot of opportunities. There are many health challenges which have not yet been answered. And I say, once Sri Ravi Shankar ji, Art of Living founder, said me, Suresh, if India has to change, social change will be governed by women in family, and healthcare changes will be governed by nurse. That day, the women in families, in nurses in hospitals, the day they start will be leading and empowered, the country will change. So I'll say that every nurse must start respecting self as an individual and as a professional, and have a belief system that I'm not less than anyone. We must come out of inferiority complex, and
exactly,
we should start believing on ourselves, and we must have a passion, dream, and humility to do it. I think we will be able to make a huge change, and whole country is looking towards us.
Agreed, sir. Agreed.
That's the message from my side, and it was really great listening to you, Madam Deepa. I'm first time meeting you on screen.
Pleasure, sir. If the words come from you, I am really honored.
Great listening.
Thank you, Suresh, sir. And yeah, we Indian nurses, we have lots of potential, sir.
Yes.
Lots of potential. Sir.
Yes.
Thank you so much, sir. For this. This was very motivating. I really wish everyone, I think everyone will echo this, my feeling that it is the last, your take-home message was very motivating, sir. Thank you so much, sir. And then I'll ask Madam Deepa to give us a take-home message.
I would say, in continuation of what sir said, be in the system to change the system. So no one will come to do anything for you. We say the accreditation body would do, our council would do, this one will do, the new nursing commission would do. No one would do. It is I who have to do. I who have to stand for my nurses. So you have to be in the system and bring in the best changes you can by having a positive note about you that yes, you can do it. There would be challenges, face those. Why there are no challenges at home? We have huge challenges at home also, but we still have fought through, and we are coming every day, breaking those challenges. We are coming every day to our workplace. When we can do it with such vigor in our personal life, I'm sure we can do marvels in our professional life. That's the take from my side.
Thank you so much.
Thank you all of you all for having a patient hearing.
Thank you so much, ma'am. So both the take-home messages were what I really believed in as a nurse, and I'm really very happy. Personally, I'm really very happy that what I wanted to tell people, our nursing colleagues, both the speakers today has, echoed those messages. Thank you so much, both of you, Suresh sir and Deepa ma'am. And I think we'll wind up today with this word of thanks to both the speakers and our team, TNA Delhi branch and TNA headquarter. Thank you everyone, and to the participants, thank you so much for being here. We have 70 here right now after 1.5 hours. Thank you so much everyone.